All right. So I'm Josh Hansen, another of the third-year residents, and I'm not going to show any videos of people almost suffocating, so you can all take a breath and relax. So I'm going to present a project that I've done over the last about a year and a half of improving healthcare access to our collegiate athletes. No disclosures, and the next step for me is I'll be traveling to Oklahoma with the University of Oklahoma, working primarily with the University of Tulsa and Oral Roberts University to do a sports medicine fellowship. And after this, I'm taking applications for someone who wants to drive the U-Haul there for me, or preferably take my 3 crazy kids and I'll drive the U-Haul. So talk to me after this. So I'm going to start here with our local university, Weber State. If we're from here, we're all familiar with the athletics here. Really good basketball, football, and other sports that are participated here. We have what I think is really good medical coverage, really quality medical care coverage for these athletes. It starts with many of our Intermountain Health physicians, our fantastic family medicine residents here at McKay-D, an athletic training program that's ran through the university. This coverage includes game coverage, event coverage, training room clinics, phone calls, text messages, and getting these athletes in to see us in the variety of our provider clinics. What's a little bit less known is this huge group of club athletes and non-NCAA athletes. These are teams like dance and cheer and rugby and baseball, bowling, table tennis, pickleball. Here's a picture of our cheer team who just went about a month ago to Daytona and won a 6th straight national championship in Daytona Beach. And so these are very high-level athletes who are traveling across the state and across the country to participate in their sport. As I said, over 400 total student athletes in these variety of sports. They typically don't compete with any athletic scholarships. There's a few on like the cheer team and dance team who may get some partial scholarships, but the majority of them just love their sport, are here to compete, and are paying their own ways. They have also historically gone without direct supervision of athletic trainers and especially without any physician coverage or oversight in these sports. As I was starting this project, I had a story from one of the hockey players. He told me about his teammate a year or two ago. They were several hours away from home competing in a tournament. His friend tore his ACL, MCL on the ice, and the teams just had to get him off. And then as they're away, it was just one of the fans in the stands for the opposing team who was willing to put him in their car, take him to the emergency department, and drop him off there, and wait for the tournament to end for his teammates to come and pick him up and bring him back home. And I hear that story, and I thought to myself, there's got to be a better way to provide care for these athletes. And as Mike discussed the Quality Improvement Project, that's what brought about this. So my project, over the course of a couple years, broken up in 2 phases. The first phase, October of 21 through April of 22, was really a quality improvement project. And then the second phase led into more research and data gathering and data analysis. And so this first phase was, again, looking at this problem of how do we provide better care for these athletes who are underrepresented. We discussed, there's a possibility of a bunch of different options. The thing that we felt would be the best and that worked the best for them and for the NCAA athletic department was for us to create a second free on-campus clinic specifically for these athletes. So along that process, had to develop relationships with the athletic training program and a particular athletic trainer who was willing to take on this venture. Worked on a communication and clinic workflow between us and the athletes, develop a clinic charting system, how would we document the care provided to these athletes, and then to email and invite and hope that athletes would come to this. And so here is a picture of the small training room just in one of these, I don't know my directions where I am now, but one of these buildings here pretty close by. We have a small training room here with several exam tables that we decided a half day a week that we would start this free clinic for these athletes. And so just quickly kind of going through the process of this, I developed this algorithm for how the athletic trainer and I would work on this. The athletic trainer who went and actually provided some in-game coverage for some of these events and then was also available by text or phone call for any injuries for any of these athletes. She would evaluate and determine if this was an urgent need or a non-urgent. If urgent, I would get a phone call or a text and help develop a plan of action, whether sending to the urgent care, getting set up with one of my residents or faculty colleagues. If it was a non-urgent need, the athletic trainer would just schedule on one of these weekly clinics that we had set up. We would then meet up at that clinic. The athlete would arrive at their scheduled time. The athletic trainer and myself would evaluate the athlete together, develop a treatment plan, and then this on the left is the paper chart that had been used. We'd fill this out and then bring it back to our primary care clinic where we would scan it in to the electronic medical record. So going into this kind of quality improvement, I won't spend a ton of time on this portion. The aim of our study was we were hoping to just have some athletes come to this. The goal was 10 patients on average per month by the March of that first year. As we see on the graph here, the solid line is actual patient numbers per month, and that dotted line is the average. The trend of that continued to increase throughout the duration of this phase. I also did spend a little time collecting some preliminary data of interest, who went out for referrals and diagnostics and procedures and those types of things. As we can see, we were pretty surprised with how quick this took on. By November, the aim of our study was met, and we were already averaging 10 patient visits per month by November. If you were here last year and you happened to stop by the poster presentation, this was my poster that I presented on this portion last year at this conference. So this gets into phase 2, which has been really the last year of data collection. Again, May 22 through January of 2023. Some questions that I had of particular interest is, what would be the clinic longevity of this? Was this a several month project that would then wash away and would lose interest by the athletes? I wanted to look at some team-specific visit numbers, injuries, also what types of injuries or chief complaints these athletes were coming to see me for, and then some potential financial implications of this clinic. And so kind of looking at, first off, a bit of data for the entirety of the project. This is both phase 1 and phase 2, just clinic numbers. A total of 186 athletes were evaluated just in my clinic. That's not counting any athletes that I talked to just over the phone or that I got into other avenues of care. I averaged about 2 to 3 clinics, half-day clinics per month, and those clinics lasted about 2 hours, just depended on how many athletes needed to be seen. And we can see the total clinic numbers, again, the actual numbers are the solid line, and the kind of trend is the dotted line. The clinic numbers fluctuated by academic year, as we could expect with the college athletics, but the overall trend continued to increase throughout the year and a half of this project. Now looking just at some phase 2 specific data. So this is these last several months, total of 96 visits during this time period, looking at specific teams coming in to see me in clinic. And we can see the cheer team took up a vast majority of my time. 75% of the time was taken up by the cheer team. We have a list of all of these other sports. I saw several hockey players, dance players, rugby players, baseball players, but there's this large group of athletes, 19 teams and almost 400 total athletes that were unrepresented in my clinic. Now, several of those I know for a fact were seen in other clinics, and so were not calculated in my data, and so they were being seen, but this is still a large population, unrepresented. We can look at some of them, maybe the bowling team and the billiards team were not getting injured, and that would make sense. However, there's 80 soccer players, there's lacrosse and rugby teams. Those are athletes who are getting injured, and for whatever reason, were just not being captured by my clinic. Then looking at the chief complaint, again, of these 96 visits during phase 2, as we'd expect with the majority of these types of sports, the knee and the ankle and foot took up a large portion of the injuries. I don't have specific data for what the the actual diagnosis was, but generally knees and ankles injured by these athletes. I also have hand and wrist and back and shoulder. I've highlighted, I was surprised with the mental health complaints that came into the clinic. I set it up more of an idea of an MSK sports-related injury clinic, but had about 10% of my time spent there in clinic talking about mental health specifically. Now on to some potential financial implications. Again, this was a free clinic staffed by myself. These are the potential billing, E&M billing codes that I would have billed based on the chief complaints, the workup, and diagnostics from these visits. It's pretty well even, about 50% level 3 and 50% level 4. Again, that depended on what I ordered, where the injury was, head injuries, those kind of things requiring a little more acuity and would have resulted in a higher billing level. So then looking at the percent of these clinic visits, again in phase 1 and phase 2, and then an average over the course of the project as far as what ancillary services were brought about specifically by the patients seen in this clinic. Broke it up as x-rays, MRIs, physical therapies, and surgical referrals. I don't have the exact numbers for how many of those athletes who were referred to surgeons got surgery. I would estimate it's around 95 to 100% of them that I sent to the surgeon ended up getting surgery. So I was actually surprised. Of these visits, 11% of athletes ended up getting surgery. Nearly 20% got physical therapy, 20% needed an MRI, and a large portion, again, needed x-rays. This did fluctuate from year to year, and I would assume if this project continued on for several years, that would fluctuate. And so it'd be interesting to see if those averages stayed that high or if they leveled off somewhere slightly lower. All right, so as far as some of the limitations of this project, as I've mentioned, I lost a lot of data points by them going to see other providers. But I would say that most of those are seeing those providers as a direct implications of starting this clinic. There are also that huge population of athletes that weren't evaluated by myself in the clinic. Again, the cheerleaders dominated a lot of the time in the clinic. Unclear whether they just got hurt more often than others, or if I took you back to that picture where the training room is and I panned 10 feet to the left, there would be a door, and directly out from that door is where the cheerleaders practiced. And so they had very easy access to myself, and the athletic trainer would often just walk in to be evaluated while I was there. And so that could be a large role as to why I saw so many of them, but still a lot of athletes who may not have known about the clinic and had not reached out to be seen by me. This was a free clinic, with a resident running this. Interesting to think of if this was billed similarly or billed traditionally, would I have similar results? So as far as a discussion, overall I think this was a really successful quality improvement project and gathered a lot of interesting data points. I think some of the project would need to continue on, and we need to look at more specifics, again, to see if the longevity, if this would continue on, and to really tease out if this is something you could turn into a billable clinic or if those numbers would alter based on that. Overall, it was incredibly beneficial to me doing a quality improvement project, starting a clinic from scratch and developing relationships with an athletic trainer and kind of learning how to do that provided great education for me preparing for my fellowship. Also believe that we provided a really quality service for these athletes. This showed with that algorithm how we triage these athletes and got them into the clinic. If this is going to be, if this type of project is going to be taken on, you have to have really good relationships with the athletic trainer and have a really good understanding of how to run this type of a clinic. Again, I was really surprised by the mental health outlet. I actually had one athlete who came to me and was pretty moderate to severe depression, and kind of triaged him there, was able to work with the athletic trainer and the support of the university, and got him in to see me in my normal family med clinic so that I could really address his mental health concerns. But he told me he never would have gone to see a normal doctor or gone to the student health department. He just felt more comfortable for some reason coming into a sports clinic. And so this unexpected mental health outlet for these athletes. Again, potentially financially viable for a physician as well as for the physician group, whether it's billed traditionally or whether it's just going off of the ancillary services. There is a potential financial implication of this. I think this was a proof of concept where, again, if you build it and you maybe send an email out to some people, the athletes they're getting hurt and they want to be seen and they need to be seen, and they'll come to a clinic like this. And for me going forward in my career, looking into the possibility of employing a similar method to this in the future, whether it's at a junior college, another college like this with club athletes, whether it's high schools or other local organizations that have high-level athletes who need quality and continuity of their musculoskeletal care. So I want to give a shout out and a big thanks to a lot of people who helped me over the last couple years. Faculty has been incredibly supportive in allowing me to do this project. Had several residents who helped me along the way, who filled in for me in the clinic when I was unable to go as well. The athletic trainer, Brianna Cutler, who I think ran this clinic more than I did, to be honest. And then the Weber State University and the residency as a whole for just allowing me to participate in this. All right, appreciate your time.